So I'm Dr. Muniza Siddiqui from the University of Dundee, and I'm here presenting some results we have from the India-Scotland Partnership for Precision Medicine and Diabetes. And these are really the preliminary results from a cross-sectional study of 100,000 individuals from South India and United Kingdom. So essentially what we found were that what are well known to be traditional risk factors for the onset of type 2 diabetes do not appear to predict risk for onset as well in South Asians as they do in white Europeans. Primarily things like obesity, calculated by body mass index or waist circumference, while strongly associated with the age at onset in white Europeans. Very obese white Europeans will develop diabetes quite young, whereas those developing diabetes at the age of 60 or 70 or later tend to be quite slim. This effect was completely absent in South Asians, who were generally a lot slimmer than white Europeans when they developed diabetes, and never really showed a strong association of increased obesity with age of onset. The other very striking result we had was with regards to blood pressure. It's well known that the metabolic syndrome, which is how diabetes is generally described, in white Europeans is associated with not only obesity, as I just mentioned, but also hypertension. And we definitely see that in our white European population, where young onset diabetes is associated with quite high systolic and diastolic hypertension. But this effect was again completely absent in Asian Indians, who in comparison had very normal systolic and diastolic blood pressure, 120 over 80 being the norm for those diagnosed under the age of 40, which was also quite puzzling. But finally, the area in which we did see a big difference was in beta cell function. And beta cells obviously are a marker of insulin secretion, and we could see quite clearly that in those diagnosed young in South Asians, there was a complete depletion of beta cells that was not evident in white Europeans who were diagnosed at similar ages, suggesting that that's really where the answer lies for Asian Indians. Actually, what's really striking in our results was that it's pretty well known that South Asians develop diabetes much younger than white Europeans, but in this particular study, in this particular population, we're looking at a 15-year difference in the age of onset on average. Part of the population level effect that's occurring here is that, aside from the ethnically driven risk, is that Asian Indians in this study are from a private clinic system for the management of type 2 diabetes. So it is possible that we're looking at a slightly more extreme group of people with type 2 diabetes. But it's not uncommon in India, if you have a chronic health condition, to seek management in a private specialist facility. What's particularly of note here is that if we are looking at a slightly more extreme kind of or more aggressive type of type 2 diabetes, what's even more striking is that in spite of that, there is an absence of adiposity and hypertension, which is really of note. Obviously, before this becomes part of routine care, there would need to be plenty of clinical trials done to understand, first of all, what drugs would best work in South Asians, because clearly what we are starting to see here is that the pathogenesis of the disease is very different. And so I think the same therapies may not work to the same efficacy in these two ethnically different populations. I think and we're seeing this across the EASD, and several talks this year have focused on perhaps a different standard of screening for South Asians, whereby they're screened younger, perhaps should be screened more frequently, because this is noted both in our study, which is looking at indigenous South Asians, as well in some studies that I've just been to today that have discussed South Asians living in the UK, for example, who, when they are diagnosed with type 2 diabetes, seem to have very high HbA1cs, which perhaps suggests that they aren't seeking healthcare as routinely as white Europeans are, or perhaps they aren't being sort of compelled to be screened as often as they should be, given that we already know they are at an increased risk. So I think the main message for primary care primary care physicians would be essentially to just be a little bit more aware that the disease comes on that much sooner in South Asians, that it may not necessarily come bundled together with our idea of metabolic syndrome, as in those people may not be quite as obese or as hypertensive as you might think they would be to have risk at that young age. Essentially, what we're looking at is a beta cell issue, so perhaps tailoring medications for that might be the future of primary health care for diabetes in South Asians.